As you know, the muscle channel disorders are rare, mostly inherited, and they may present with myotonia or stiffness. And we see the same symptoms in children. So they also present with myotonia and stiffness, but the presentation and the recognition may depend on the parents to identify these symptoms. So I will try and explain what sort of symptoms we see, but the identification of these disorders is similar to adults. So we see paramyotonia congenita, myotonia congenita, periodic paralysis, and Anderson-Tavern syndrome. But in the infants, we also see the laryngospasm presentation. Lately, we started seeing the congenital myopathies as well, and there's the malignant hypothermia that Deepa alluded to earlier. So all these presentations are possible, but most of the ones which I've circled are the ones which we see in clinic. And this is the entire spectrum. So you see paramyotonia congenita, myotonia congenita, hyperkalemic periodic paralysis, hypokalemic, normokalemic, and Anderson-Tavern syndrome. And this is the work that we published with the 38 children that we look after. And if you look at the symptoms, they can present right from birth up to adolescence. And most common presentation is within the first year or first 5 years, and then a small number present a bit later. So here you can see that they may present with fists being clenched, eyelids being stuck, or intermittent squint. You can also see babies may gasp or choke in cold weather. They may have double vision, leg cramps, funny gait, falls, or difficulties with exercise. And depending on the age of the child, you may have any of these symptoms. In infancy, it's often the eyelids being stuck or fists being clenched. And in the older children who are mobile and ambulant, we see problems with exercise, falls, and leg cramps. Quite a significant number of children present with, like yourselves, having some family history. So there may be a parent already affected, and the parent then notices the symptoms in the young child, who then get referred to our clinic, or the episodes of weakness and paralysis. But there's a significant delay in the patients who don't have a family history. And we've tried to, increase the awareness and education of people who don't look after these children well or, often. And here you can see that sometimes it has taken as long as, a decade or more to get to the final diagnosis. And you may have experienced similar delays in your own case. I won't dwell too much on the triggers because you have seen these slides with regards to temperature, exercise, and food. The same triggers apply for children, and similarly exertion. So, doing PE in cold weather, exercise again at school, swimming lessons. These are areas where you might see the children presenting with symptoms. With regards to treatment, the same principles apply that Deepa talked about earlier. So we try and avoid the triggers. We speak about the acute episodes of weakness and paralysis, but also managing the myotonia and starting to warm up a little bit before you start to move. For infants with breathing problems, we also have respiratory and bulbar support. Medications are again similar, although the research evidence is more in adults. We don't have studies in children, so we tend to rely on the adult data to guide the treatments in children. And this may be stiffness treatment with myotonia, for myotonia with mexilitine, but there's also use of lamotrigine and carbamazepine. We don't have many children using lamotrigine because we're still waiting the results of the trial that Vinu mentioned earlier. But we do have children under 5 who we tend to treat with carbamazepine because we have limited experience of mexilitine in children. And the other main point for mexilitine is that we don't see the cardiac side effects that we see in adults in children because of the rarity of cardiac disorders in children in terms of ischemic heart disease. So moving on to the other, periodic paralysis management, again, the principles are similar. So we tend to use potassium or acetazolamide, and then some of the other drugs which were mentioned earlier are occasionally used. Again, sometimes with the periodic paralysis, if there is no family history, the symptoms can be considered, falsely diagnosed as functional. So one has to be very careful when assessing children who have acute episodes of weakness where it's not recognized early. So these are the main treatments. We haven't seen any major side effects apart from heartburn with mexilitine, occasional abdominal pain or headaches, but otherwise most of them do well on these medications. We have to do quite a lot of work with support in school, and I'll share in the next slides. So this is, how our CNSs can help. They can provide any support with, if your children have any problems with symptoms of myotonia, which are being difficult to manage. If you contact them, they can give you a phone call or even call the school if they need to speak to somebody in school or a school nurse. They provide you with written information about the condition, also give you leaflets about diet as well as exercise for the children, discuss various treatment options. And at the moment, we have Emma Scott, who's one of our CNSs, because Sean, who is our permanent CNS, is on maternity leave. So Emma Scott, she couldn't be here today because she's away, but she will support you with all the symptoms and guidance. They also do telephone clinics. So once we prescribe medications and you start the medication on the children, they can ring you in about 4 weeks to see how the medications are working, if you have any side effects. They also work with school, college, and clubs. We also have a social work support worker who can help with some difficulties if the children have any problems with mobility, etc. And these are the contact details should you need for the CNS team. We have these information leaflet, which we hand out in clinic once the diagnosis is made. They're all on our website for individual conditions as well as the diet, etc. And for the school, they provide letters for support in school. So they may be to do with use of laptop or extra time in exams. And again, explaining to the school about how, why PE should be done, if possible in a warmer area, or the children should be allowed to wrap up warm. And sometimes modification of PE temporarily is also needed until treatment starts to work in. And we support with the educational healthcare plan, which is essentially a document which lists the amount of support and the type of support that the child would require in school. The main challenges that I face in clinic, in the pediatric clinic, is use of mexiletine. So sometimes the GP, because it's not licensed in children, I find that there's a lot of pushback regarding the prescriptions for mexiletine from the pediatricians and the GPs. And we often end up prescribing at gauche for a lot of the children when it comes back to us. The second problem, as I mentioned earlier, is the delay in diagnosis and failure of recognition of the symptoms, both myotonia as well as periodic paralysis. And a number of cases still remain unresolved, so we don't have much. If we find a variant, then we have to rely on the Queen Square team to do the functional work, which was shown up earlier. So these are the main challenges, and I think this is the summary slide. So they may present with various symptoms of stiffness or weakness. We need to recognize these early to minimize delay. We make sure we examine for myotonia, warm-up, and weakness in the clinics. And we consider testing for this if we have children who have congenital myopathy or even other presentations like laryngospasm. And there are lots of treatment options. So we just need to educate everyone around us about the treatment options. And we work closely with the lab colleagues.